taken the liberty of, instead of making this a presentation about antimicrobial stewardship in general, which I assume a lot of people here have heard of or work on constantly, or possibly even went through the PHAC training with our program that was arranged a few years ago, I've decided to make this more of a discussion of some of the more specialized things that our program is doing and sort of how we see those fitting into the broader picture of antimicrobial stewardship. And I really do want to emphasize that if any of you have anything you want to say, just send Jason a chat. He'll be able to see it. And let me know. I'm happy to interrupt the presentation at any point to elaborate or discuss things. And I mean, sitting here in my son's room, surrounded by Godzilla figurines and D&D books, you know, I've essentially abandoned most forms of professional dignity already. So no worries about that. I enjoy doing these things face to face, but doing them online is good also, since you get to discuss it with people who you would otherwise have absolutely no travel budget to ever meet. So sort of to get going then, Do Bugs Need Drugs is a community antimicrobial stewardship program that supports the wise use of antibiotics. We're within the Alberta Communicable Disease Program, which is part of PPPH, Population, Public, and Provincial Health, and which until recently was PPIH, Population, Public, and Indigenous Health, but now Indigenous has been cut off and expanded into the Indigenous Wellness Core, which we obviously work closely with, but is now different. And hold on now. Yes, so the program was started by Dr. Edith Blundell-Hill more than 20 years ago in Grand Prairie, Alberta. And in 2004, she moved to British Columbia and started an adjacent program there, which is also Do Bugs Need Drugs, but is housed in the BC Centre for Disease Control and is obviously completely independent of ours, in my program, in a formal sense. But the two programs essentially operate as fellow travelers, where we share resources, sit in on each other's meetings, and essentially provide a second voice for suggestions and critiques. And in Alberta, Do Bugs Need Drugs is guided by still Dr. Edith Blundell-Hill, Susan Freiders, and Dr. Joan Robinson, a infectious disease pediatrician. Susan Freiders and Dr. Blundell-Hill are the authors of the Bugs and Drugs app, which is also a prescribing tool that's separate from the program. In BC, it's advised and led by Dr. David Patrick and Nick Smith. So I wanted to start off, I have three kind of text-heavy slides, which are not typical of the rest of my presentation, but I do want to actually discuss what community antimicrobial stewardship means, since most antimicrobial stewardship in the most formal and invasive sense takes place in acute care centers or hospitals. And so one answer is that community antimicrobial stewardship is a technical approach in which outpatient prescribing is subjected to various hurdles to make it evidence-based. And I suspect that most people here are familiar with these. An example is, for example, the Choosing Wisely campaigns. Here in Alberta, we did the appropriate diagnostic approaches for UTIs for quite some time, and those have recently become a focus throughout Alberta now, throughout Canada now, with AMI and Choosing Wisely and other organizations emphasizing those as well. Continuing medical education. And let me give a plug right now to something the BC CDC is developing, which is a set of, I believe, 14 modules on appropriate outpatient prescribing for antibiotics that aren't live yet, but will be soon, and are hopefully going to be accredited nationally within Canada. So in one sense, community antimicrobial stewardship is the kind of technical approach to proper prescribing only applied to outpatient settings, where about 80 to 90% of all antibiotics are prescribed. A second thing and third thing that I hope it'll be someday, which it is not yet, is where there is strong current data on outpatient prescribing patterns, and where that data is used at a clinic level, at a low administrative level for quality control. And to my knowledge right now, there is no one who is trying to exert strong quality control on outpatient antibiotic prescribing. I don't actually know what that would look like, but it's something that I think at some point will be brought up. Sorry, Jason, did you have something to interject there? Okay.
Nope, sorry, that might have been a background blip there.
Okay. Yeah, no worries. No worries. Okay, so then the second answer to what community antimicrobial stewardship is something that our programs both do, Alberta and BC, which is community health promotion focused on the public about proper antibiotic use and the dangers of antibiotic resistance. And so this takes the place of occasional media campaigns on hand washing, on talking to your doctor about whether you need antibiotics or not, things like that. It also takes the place of technical materials on disease management and antibiotic use that aren't intended for prescribers, but are intended for the public. And day to day, it often takes the place of, it consists of targeted outreach to high antibiotic users, elderly, families with young children, etc. The challenge of community antimicrobial stewardship is the one that most public health outreach campaigns suffer, which is how actually to get in touch with people, how to reach them, and then if you believe that you've reached them, how to assess how effectively you communicated with them and whether that has any effect going forwards. And I don't have good answers to those today, or I'd share them with you. I'd be happy to talk about any approaches to that. And then the third answer is somewhat more forward-looking, and it's one that I think of as sort of structural. And as opposed to health education or community health promotion, this one essentially consists of giving communities resources to understand and participate in AMS as one aspect of a participatory health model that I personally believe will become more important as antimicrobial resistance becomes more important. And some of the experiences of the pandemic have really driven home for me the importance of this, both for the public, but also for people who work with the public, in the sense that what we do day to day tends to be how we'll react when a situation becomes more serious. And so I think that one of the basic issues around antimicrobial resistance is that, like global warming, it's a mass action problem where the small contributions of the individual can be seen as beneficial to themselves at the same time that the aggregate contributions of everyone in using antibiotics become deleterious. And so there has to be some sort of community level structure for addressing this and for preventing perverse effects in the future, which I'll touch on very briefly at the end of the presentation. So anyway, so enough of that for now. I just wanted to lay out the three different areas that we work in and make the unfair generalization that right now Alberta, it tends to be more engaged over here on the left in developing materials that are intended for community use and applying them, and that BC is currently developing a magnificent suite of materials for prescribers, sometimes in specialized niches, sometimes more general, and sometimes cross-cutting between prescribers and the public, and that they are currently somewhat more focused on professional-facing resources. But in both programs, the ideal, I believe, is to integrate these into an effective, comprehensive set of actions. But short-term plans and budgets and pandemics and things like that have, I think, caused both programs to focus on what makes sense in the current moment and to sort of develop larger plans for the future. So talking about Alberta's emphasis, we focus, first of all, on hand washing. And one reason for that is hand washing is the most basic form of infection prevention and control, which everyone expects. And the pandemic has put us in a strange position of having everyone interested in it. So that for right now, there's actually a point in the pandemic where I was wondering if my program should continue doing hand washing, simply because everyone else was also, and everyone else had more resources and better reach than I did. We are going to continue doing it. And first of all, just because it's a very basic tool that's used for everything. But secondly, because in a way, hand washing is something that we can give to everyone. It's appropriate. Our small posters are appropriate in any setting. And so we can offer them to someone as a way to open a conversation about how to use some of the program's more complex materials. And so this here is the most basic poster. It's a 5-step poster intended for kids who are between about 3 and 6. It's our simplest one. And we also have 2 more posters. One is for kids about 6 to 8, and another one is for older children and adults. And then this here is soaping up. This is one for older children and adults. And again, these are basic tools. I'm sure everyone's familiar with them. Our more complex tool is what we call the Guide to Wise Use of Antibiotics. And this is a pamphlet that was put together quite a long time ago by the program and then revised recently by the Alberta program's expert brain tank, Edith, Susan, and Joan, and myself taking notes. And it's a 24-page pamphlet that it was put together by healthcare professionals, but organized by an actual graphic designer. So in my opinion, it rises a bit above the sort of standard health promotion PDFs that people like myself like to produce. And it's public friendly. And what it aims to do is to discuss antibiotic resistance, bacteria and viruses and the difference between them, hand washing, and then in the light of that, it goes over 7 or 8 various ailments from a symptomatic perspective and discusses how whether symptoms such as colds and runny nose, sore throat, cough are likely to be caused by a virus or a bacteria. If they are caused by a bacteria, are they dangerous or not? Do they need treatment? What should you talk to your doctor about? And so its aim is to both support the public with symptomatic non-antibiotic treatment, but also to support them in speaking with the doctor if they want to discuss antibiotics. And here are the basic breakdowns of how it breaks out. It has 4 pages on basic AMR, 2 on hand washing, 13 on symptomatic management. And then one of the main things that we added was 4 final pages, which are unrelated to actual antimicrobial stewardship, but which are to help people in identifying dangerous and emergency symptoms. And we really spent a lot of time on that, with the goal being that any symptom that's an emergency or potentially dangerous be identified and communicated. And yet at the same time, we don't say something like, if you have a rash, go to the emergency department, given that large numbers of people who use information like this live in rural communities where telling someone to go to an emergency department can be a major undertaking. It can potentially involve expense or missing work or things like that. So we worked very hard on that balance for it. And again, the goal is improved prescribing, improved knowledge, and improved communication between the patient and prescriber. This updated version only exists in electronic form right now. And the program is actually moving more directly towards different electronic media for disseminating information. And then on the back here, you can see the 3 key messages that the program tries to promote: that hand washing is the best way to stop the spread of infections, that bacteria and viruses are different, antibiotics only work against bacterial infections, and that antibiotics should be used wisely. And we emphasize the wisely instead of correctly to emphasize patient choice. We try not to be prescriptive so much as supporting intelligent use. So we did that, and since the guide was first developed 20 years ago, it's been translated into 8 or 9 languages. And when we reworked it, we retranslated it into 4 more, three of them Tagalog, Tigrinya, and Urdu, and went through all of these translations at the same time. And so these have always been a major effort of it, and they currently exist. And then also 3 years ago, with support from our initial collaboration with PHAC and Denise Gilby. I don't know if anyone here went through the training that Denise organized between Alberta, BC, Saskatchewan, and Manitoba. But one of the fees that PHAC paid to Do Bugs Need Drugs for working on that went to developing the first of our First Nation language translation into Cree, which we put out at that time. And since then, very recently, in fact, at the very end of the budget year in March, we were able to get a permission to spend some unspent money in PPPH to further translate the Guide to Wise Use into Blackfoot, Dene Thulane, and Stony Nakota. Blackfoot and Stony being two First Nation communities that are concentrated in Alberta, and Dene Thulane is one that's found between northeastern Alberta, the Northwest Territories, and Hudson's Bay, as far as that. And these are right now a major focus of the program, simply getting them up to speed, and then using them will be a next step, which I'm going to talk about some. And we've also put together hand washing posters in Blackfoot, Cree, Dene, Saulteaux, and Stony. And eventually we hope to have simple hand washing posters in all of the First Nation languages of Alberta, including Michif, the traditional Métis language. And then regardless of how extensive language use is in the community. And then these sets of materials are going to be our main offering as we set up an Indigenous community strategy in partnership with the Developing Indigenous Wellness Core at AHS. And so talking first about because the translations are a large effort of ours, and they're a useful tool, but they're a tool that has to be developed in very particular ways. I want to go through just a few of the issues that we went through. For the immigrant translations, AHS's system works sort of like a vending machine. You put in money through the contracting process, and eventually a translation comes back to you, where you have no input whatsoever with the actual translator, and then you go and find someone who can validate it. And in Alberta, there's a large population of foreign graduates of medical schools, and so every single one of the languages that we had is backed in some way by an actual medical school in another country where the language has been formalized, systematized, and professionals are trained in it. So checking them, it was difficult finding people to do it, but the actual checking was fairly straightforward. And with every single translation, with the possible exception of Spanish and Punjabi, where there were no issues identified, it turned out to be worthwhile. So for example, the translation of English blue lips, which in English is idiomatic for is having trouble breathing, in Chinese has to be rendered purple lips, which might seem like a distinction without a difference. But imagine what you would do if you were recommended as just a general member of the public to say, read something. If your child has green lips, take them to the emergency room, because green lips is something that we literally don't say in English for anything. It actually comes across as nonsense. And when you hear nonsense as a health recommendation, and you're a member of the public, you can produce any type of divergent thought or action. For many languages, the infection cold was rendered as temperature, and a very specific term of measles circulating, where we were talking about a geographic area and not an individual body, was very often translated as if you have a rash moving around your body. The Urdu translator included a number of terms normally restricted in medieval Persian poetry. Our validator thought that possibly they had been using Google Translate, which produced some more literary adaptations. The Somali translator translated measles as muscles and insisted it was correct, which led to a somewhat absurd set of exchanges where I would Google the Somali word using my version and then send links. All it would bring up was links to Somali bodybuilders. And then I would send these to the translator and argue that it couldn't possibly be indicating measles in this context. And a more difficult situation, which also came up with regards to the Tigrinya translator, is that of all the languages we use, Tigrinya is the least standardized. And so the version that we got was somewhat more acceptable for people from an Ethiopian background than an Eritrean one. And so we had to do a bit of extra work on that. And then this is an example of just some of the work that came out of it. This is Chinese, one of the versions up here. This is either Persian, Arabic, or Urdu. I can't identify which one. This is Korean with the Do Bugs Need Drugs logo. This here is Plains Cree, Punjabi, Somali, Tigrinya, and Tagalog. For the First Nation translations, we had to eventually adopt an approach that was careful but somewhat less uptight. And this is related to, stems from the fact that I did not quite clue into at first with Cree, which is that they're community level languages that are not standardized for communities that are used to dealing with English speaking medical hierarchies. So for that reason, you simply can't quite go through them checking on the standardization in the same way that you would a Spanish or a Punjabi or Somali translation, because it may not actually exist in that sense, and the people who are using it aren't going to be expecting it to exist. And treating it as standardized when it's not can lead to the just as confusing an outcome as not standardizing it. And then a second problem is one that's wasn't such a big issue for Cree, but will be, especially for Blackfoot or Stony, which is that the translations are frequently done by respected experts living in the communities where they will be used. Getting it reviewed is not simple or straightforward. So for example, Stony in Alberta is spoken in a community of about 3,000 to 5,000 people concentrated outside of Calgary. I don't know who my translator will be, one of the regretful parts of the AHS's process, but when I get the translation, I will not be going to that community and waving it around and saying, could someone check this for me, please? I'm concerned that it might not be correct. You don't have quite the same standing in that situation to do so. Let me check my time. And then a third situation is that the usages of the translations are fundamentally different. For the immigrant language translations, one main goal is introducing people to Canadian medical culture. In other words, we want them to understand how antibiotics should be used in Canada. For First Nation language translations, one main goal is making Canadian medical culture more welcoming. The actual existence of the translation is at some level meant to be a symbol that this issue is one that should be in your community, customized for your community, and that you can discuss and go over it on any terms whatsoever. And then this passage for sore throat shows is an illustration of one of the issues of standardization, where the critical aspect here is distinguishing between viral sore throats and a strep sore throat. And so in English, when you say this, you depend upon the scientific term strep, which has become part of the language. And whether it's safe to do that in Plains Cree or not is a very tricky question. It may vary by community. And so here at the very end, where you see the long term Wisa Kiko Takana Spinawin, apologies for my pronunciation, that literally means strep throat in Cree. But unlike most of the other translations, we took the liberty of including parentheses there in English to make sure that it's not confused with the broader term up here, Wisakiko Taki Wina, which does not have spinawin on it. So very, very specific issue. And then a final issue for these is font. This is the Soto translation of a hand washing poster. And because the font doesn't contain any unusual characters for English, we were able to put it in Comic Sans, which is appropriate for children. Whereas with the Dene translation, where you have a large number of non-standard symbols, which Comic Sans has not taken the time to produce, we put it in that. We have to leave it in a much more technical version. So now going on to the British Columbia, I want to go over a few things that British Columbia is doing very briefly. This is an example of some of their prescriber-oriented materials on dental prescribing. They're developing these also for nurse practitioners in some situations. This is an example of material that is public-facing, but can also be worthwhilely distributed to a doctor, which is looking at my email signatures and Comic Sans, which is looking at penicillin allergy and how a lot of people, a large percentage of the people who think they have it don't. And that if they talk to their doctors about it, there's the possibility of them being prescribed a more appropriate first-line antibiotic instead of immediately going to a second-line one. This is an example of Bugs and Drugs, the prescribing app, which can be used off of AHS's servers. And then finally, here is just an example of the continuing medical education modules that are currently going through beta testing and will hopefully soon be accredited for usage worthwhile. I'm not including a link for them because BC doesn't want them fully shared yet, but I would imagine that within a few months at most, they'll be available. And I can notify Jason to cascade that information through Saskatchewan when that happens. And so the way that I hope to eventually put all these together is with a community-focused model for antimicrobial stewardship that emphasizes online resources that on the one hand has materials for prescribers and health professionals. In other words, the doctors or dentists or pharmacists within a community who see people on an outpatient basis. And then secondly, and this is the most aspirational, guidelines and data for primary healthcare administration. So if a clinic has an administrator, they can be given some simple data on antibiotic use in their community and a few rough and ready guidelines by which they can look and see whether it's meeting, a rough and ready version of appropriateness. And then thirdly, materials for the general public. And sometimes these are something that we use to, hopefully, to get people, health professionals or administrators on board. So for example, with the First Nation materials, generally in Alberta, communities have expressed a felt need for more health materials in their community language. These are difficult and tricky to develop. And so one way that we can work with clinics is by providing them ourselves. We develop them and give them to them for distribution and use, which achieves both our aims of reaching the public, but also the aims of working with the clinic. And then as well, what we really are working with First Nation and immigrant communities, but hopefully with the general public, is developing local people who can sort of be trained advocates for antimicrobial stewardship in that area and cascade the materials that we have and the approach through different channels. And so the integrated model combines BC CDC's professional materials, our Alberta-specific community materials, hopefully community health representatives, and God willing, someday data. The data is the hardest part, and I don't know when we're going to have a useful model for either getting that or using it. Let's see, I think I'm running low. I'm not running too low on time. So, and the basic idea is to, instead of focusing only on professionals or only on the public, is to simply try and affect all areas of the space around an outpatient prescription, so that the person receiving it has some background, the person writing it has some support, both technically but also administratively, and then that the community that both are working in has some general familiarity with the issue and is willing to look at it. And sort of the way that I see the pandemic as affecting this is I was really impressed that when the pandemic came, and here I'm talking about myself, everyone focused on hand washing. It was really the first thing that we looked at. And there are departments of hand washing everywhere. I work with public health nurses who teach hand washing. It's an important part of my program. And I thought, holy Moses, this is the time of my life to do hand washing. At the same time, at least within AHS, there were no departments of mask wearing and social distancing, even though every year we run an influenza prevention campaign which focuses on hand washing. All through our past years, I never said to myself, hey, maybe this year we should do mask wearing or social distancing. And so I was really struck, first of all, how this year the influenza season was essentially cut off at the knees. It never really happened. And that's probably because of mask wearing and social distancing. And yet, mask wearing and social distancing are still contested in the public sphere. We're sick of them in ways that we aren't sick of hand washing. We'll never get sick of hand washing, because if someone suggests, hey, maybe you don't need to wash your hands all the time, that person is looked at sort of given the side eye. And yet, with regards to the pandemic, just yesterday, the American CDC released a study that said that the chances of getting coronavirus from fomites picked up in the environment is about 1 in 10,000. It's really quite marginal. And yet our professional approach when the pandemic came was to do what we found normal, and normal is not always a professional idea. And so I feel that the public in public health is at least as important in the evidence base, both for professionals and for the public itself. And so for AMR and AMS, I think one question worth asking today is, what do we want the public and healthcare professionals to think of as normal? Because whatever that is what we're going to do when AMR becomes more serious, what we think is normal. And so things that I think we need to think about are, on the one hand, the issues of prescriber autonomy and dignity. When a primary healthcare prescriber writes an antibiotic prescription for sinusitis, uncomplicated normal sinus infection, which is 200 times more likely to be a viral disease, they can depend on their dignity as prescribers that, 2 months from now, no one's going to come to them and say, hey, what's up with this prescription? No one's even measuring that prescription. And yet maybe it needs to be measured at some point. And until you have some form of measurement, you don't actually have quality control. Quality control demands measurement. Without it, all you can do is address things from the front end with things like continuing medical education and campaigns against this. And then on the public end, the public at some point is going to express fears of antibiotic rationing, that they're not being prescribed antibiotics that would make them healthier because of a broad crisis that's not considering their individual crisis. And so particularly with Indigenous health, but honestly with everyone, it's possible for the public to have a very contentious relationship with the public health establishment. And it's important that when a crisis comes, that there's trust and pre-addressing of issues so that they can be addressed again when they become serious. So in summary, we're doing a lot of things that aren't integrated yet. Hopefully they will be one day. Any of the materials I've talked about can be used or adapted. Just check first. If you want to adapt them, it's almost certain you're able to. We just want you to take the logos off and things like that. If you want to use them in partnership with us, we're happy to do that too. We just have to discuss things with communications department and stuff like that. If there's anyone here in Saskatchewan or the Northwest Territories who's listening, and have a budget for going halves on a translation project into Western Ojibwe or South Slavey, email me. I'm up for that. My budget itself is constantly in question these days, but I could bring it up at a higher level if someone wants to. And as always, any feedback or suggestions are always welcome. We're working on models for using these materials, and especially for the First Nation and translation materials. I think the next step is using our translations not as the basis for doing our work, but as the basis for developing short little social videos usable for Facebook or playing in clinics that address people directly instead of in a written form. So thank you very much. I appreciate your listening. I hope it was interesting and not too dull. I apologize if I concentrated too much on minutiae of things that I've been obsessed with for the last couple of months or longer. And any questions or discussions are always welcome.
Thanks so much, Simon. I plopped your email address in the chat there too, so if people are interested in going halvesies on some funding for translations, that's there too. You can connect with Simon. So I guess I'll start by just posing the question. Is there anyone who has a question, a comment, something they wanted to chat about with Simon? You can either unmute yourself or plop it in the chat. Maybe I'll start and give people an opportunity to think. I have lots of questions. I could talk with you about this for days, I'm sure. But I guess it's not even really a question, but one of the things for me that I think is so understated is the importance of the education piece of the general public. And so the tools that you guys have created and the fact that you are translating them into so many different languages is such a phenomenal resource for people around the world, really, to make use of those in public awareness campaigns. And I say that, it's something, like I said at the beginning, that our stewardship program based out of Regina has made an effort to do is we get out to high schools and elementary schools and we talk to the kids about antimicrobial stewardship. And Do Bugs Need Drugs has some great resources to help with that. We've developed some of our own presentations to just kind of put the words and the ideas into kids' minds so that they become more informed adults as they grow up. And this was not more true. I read a study, I think, that I shared amongst our group yesterday that came out of the national group in Australia. And they were talking about some of the difficulties of getting people on board with this. And a big piece in that study was working with people of, what's the term now, called CALD. So culturally and linguistically diverse backgrounds. Yes. So essentially coming down to, working with immigrant populations and people who have different experiences. And you touched on this too, that, we've got people, and in Saskatchewan too, we've got people who have come from other places where in some cases, and even prescribers, we've got people who come from places where they weren't required to prescribe antibiotics. It was something where they were available over the counter. So even just giving people the words and the knowledge about how it's different, when it's appropriate, and some of the basics about hand washing and stuff like that can be a very powerful tool.
And I think that one thing that's often underestimated is that medicine has a culture too. There's very definitely a culture of medicine. And immigrants come from different medical cultures, and they have very different expectations. And if these aren't discussed openly, there's no actual way to know what people are thinking or how they feel about a particular approach to treatment. No, I completely agree with that. And I really feel that something that we want to avoid in 2040 is the public fear of antibiotic rationing, when that comes around. And there needs to be some kind of foundation for avoiding that. I don't know what it is. I'm sure everyone here who works in public health is aware that with public health, our evidence base is actually really weak. If you ask someone for an evidence-based way to convince something is true, it can be really hard to come up with that. You have best practices, but they don't produce necessarily an outcome. So I don't know. And the other thing I want to emphasize is that, especially with the First Nation translations, but also with the immigrant ones, they can't be used as we've used the English one in the past. Before the pandemic, Do Bugs Need Drugs was basically a program that would mail out flyers. That was our main effort. We just simply don't have a budget to travel all around Alberta and do things. We can try and develop partners who will work in another part of the province with us and do teaching, but we have a very limited ability to reach people in person. Even Calgary costs a single trip to Calgary costs $1,000, and so we would mail stuff. And what we're trying to emphasize now is using the translations simply as a standardized foundation for developing social media materials or people within the community who we connect with, and then that person takes them and tries to do stuff. But it's really tricky. And when you think about the fact that antibiotics are used by everyone in a provincial population of 1 million in Saskatchewan and 3 million in Alberta, you never have enough resources to really reach the public in the way that they need or you feel you need.
Yeah, absolutely.
So.
I wonder too, one of the things that I know we've experienced just working with various people in Saskatchewan is that as is often the case, antimicrobial stewardship, anyone who's involved in it, they're involved in kind of an acute care setting. So they're in a hospital or, something of that nature. And so they have limited time and often no time or budget to be able to engage in the community side of things. Is that something that you find is common in Alberta? Are there more people in Alberta who are able to engage with the community in that way? Or is it a limited, strained resource as well?
I mean, it's resources are always limited, because if they weren't, they wouldn't be resources. They'd just be something that you had. And there's a real divide here between public health measures and acute care. And you're right. I mean, the latter happen when you have extra time and extra money. And so that's why a lot of our past outreach, I don't know what it's going to be like after the pandemic, but a lot of our past outreach was focused on nursing students. We would try to connect with nursing programs at the University of Lethbridge, Medicine Hat College, the Grand Prairie Regional College, and a few others. And we would get the students to take our materials and then go use them in their community outreach practicum sessions, things like that. I mean, I'm hoping that when we get the First Nation materials fully developed, then we'll be able to use them for connecting with tribal or band administration, because I think that those organizations are actually more accustomed to putting together large public mass gatherings of people where you do some kind of discussion of a health issue, and so that might work better if we could develop something to support that. But it's a problem, and I don't know. I've worked in other organizations where you go to high schools and there are just too many to reach, at an effective level. And I don't exactly know how you do it. One thing I've thought about is trying to get my stuff into the curriculum, but everyone else thinks that also. And the Alberta Teachers Association has made it really difficult.
Yeah.
Yeah,
it would be something that would be great to, I think, be able to have that stuff built in. And again, I even just go back to what Do Bugs Need Drugs has, as far as resources, there are things that could be very easily added into various parts of curriculums at any kind of age group or grade level. That it doesn't have to be a month-long unit. It can be something that often when we get called to high schools to do presentations, they integrate it as part of their immunology unit, or when they're studying the immune system. Right. They kind of think it's a neat little piece that coincides with that. So
that's interesting. I've always thought that it would be a good part of the evolutionary biology section, but I don't know. But I mean, basically, public health is essentially the search for a partner. I mean, that's what you do in public health. You try to find someone who can reach people who you can't.
Yeah, that's great. And that's interesting too. I remember our presentation that we built originally, the whole first part of that was a piece about evolutionary biology, about the evolution of bacteria and how the evolution of antibiotic resistance and how that works in a natural setting. And it's a piece that I still have parts of in our presentation, just to kind of make that point that this is not something that we're fighting that's brand new. It has been here for as long as there have been bacteria. So yeah, that's a great piece there.
I'd actually be interested in seeing that at some point. I really think that the future of antimicrobial stewardship is slightly higher than the provincial level. And, at some point there should be something to complement, the Western Canadian AMS meetings that have been going on now for a few years. And if that could be the Western Canadian, high school curriculum module or something like that, it would
Yeah,
really be worth it.
absolutely. All right. Well, I see we're at 1:02, so I will stop hogging the floor. If there's anyone else who has, I'll give you 10 seconds for final comments or questions.
I just want to say that I really appreciate everyone giving me time to talk today. I hope it was interesting and not too abstruse or Alberta focused.
It is absolutely interesting. Thank you very much, Simon. I will give you a virtual round of applause. Thank you very much for the chat, and we will hopefully be able to do this again someday.
Yeah, no worries, no worries. And again, any interest in partnering with Do Bugs New Jugs, we're pretty flexible with that.
It's great.
Take care.
Okay, well, thank you very much. Thanks everyone for joining us, and we will see everyone again next month.
Thank you.